It's a great pleasure for me to join again this wonderful meeting. I would like to congratulate the whole Ophthalmica team for their commitment to continuous education and excellence, and I hope that we will all enjoy a fantastic meeting. So I have the privilege to kick off the session, and I'm starting with a talk highlighting structural, functional, and investigational aspects of the cornea. So I will remind you that the corneal tissue is an avascular transparent tissue with a thickness of 540, 550 microns plus minus standard deviation and a refractive power of 43 diopters, being the most important optical medium of the eye together with the lens. And we all know the layers of the cornea is composed of the epithelium, which is constantly regenerating, the basement membrane, the Bowman's layer, the stroma making up more than 80% of the corneal thickness, the Duas layer before descendants membrane, the descendants membrane, and the corneal endothelium, which has no capacity of regeneration. Now, the corneal innervation is supplied by the nasociliary branch of the ophthalmic division of the trigeminal nerve and provided by thousands of branches of the subepithelial nerve plexus and the subbasal nerve plexus, which is depicted in this picture and is very relevant clinically for refractive surgery, as I will point out later. Now, the functions of the cornea. We all know that cornea is, as I mentioned before, a major optical medium for the eye, physical barrier inhibiting entry of bacteria, supports the regeneration of epithelium by the limbal stem cells, provides structural support and transparency with the extracellular matrix of the stroma, and is inducing also, it's responsible for the keratocyte cell differentiation, which is contributing to the corneal transparency and the immune regulation of the tissue. Now, the endothelium has the function of preserving the clarity of the stroma by dehydrating the stroma, has this pump, this well-known pump function, and the endothelial cells, which cannot regenerate, but they have some migration capacity. So, cornea is devoid of vascular and lymphatic tissue, vessels, and this is well defined as the immunological privilege of the cornea. So, there is an inherent resistance of cornea to inflammation, and it's something that is very useful and a big advantage for corneal surgeons in terms of corneal transplantation and survival of the corneal graft. What has been new in the field since last time we all met up? We actually experienced the emergence of a new era, and in the cornea field there's been a major breakthrough within the last 10 years maybe, with major highlights of the corneal tissue, particularly in the domain of corneal tissue engineering and gene therapy over the last 5 years maybe. So last year, the Newcastle team, a research team, has bioprinted the first 3D corneal stroma equivalent by using bioink composed of collagen tissue, a mixture actually of collagens and cells, keratocyte cells and fibroblasts. And another major breakthrough was the first genetic approach for the treatment of Fuchs dystrophy. We all know that Fuchs dystrophy was until now, or has been treated so far by corneal endothelial transplantation, DSEK and DMEK. Now, we know that there is a triple nucleotide in the TCF4 gene on chromosome 18, and the expansion of this CTG nucleotide is actually associated not only with the occurrence of the disease, but also with the progression of the disease to end-stage Fuchs dystrophy. So there's been major research in two directions. One major approach is to try to gene edit this triple nucleotide by using sophisticated techniques such as CRISPR. And by doing that, we can just excise this triple expansion and therefore reduce the induced toxicity of the TCF4 gene. The other approach is what this group, Hugh et al., have showed actually in the lab, not in patients. They try to use antisense treatment, antisense oligonucleotides, targeting this repeat expansion of the gene. And this is something that is more difficult to achieve, but also very promising because you actually rescue the haploinsufficiency of the TCF4 gene, and you have a greater effect, not only in trying to treat the disease, but also prevent the occurrence of the disease. So, the last major breakthrough last year was the first artificial cornea made by Nishida and his group in Japan and transplanted to a Japanese female woman. This artificial cornea was all made of induced pluripotent stem cells. So they just used stem cells, stem cell lines, to create all different cell lines of normal human cornea. And they have permission to transplant this cornea to a female patient. It has been done, I think, early September this year. And 1 month afterwards, they announced that the results were very, very good. The cornea still remained clear. So to sum up, this is a direction that we're moving to. We're trying to create artificial tissue and engineer the tissue, the corneal tissue, and not only deal with corneal disease, which is clinically evident, but try to prevent it by gene therapy, gene editing. Now, coming to the investigation of the cornea, the basis of any corneal examination is, of course, the slit lamp examination, providing an overview of corneal endothelium, such as here, where you can see the goutte in Fuchs dystrophy, but also in corneal epithelium. You can observe this intraepithelial cysts in Meesmann corneal dystrophy, but also evaluate the stroma. You can see here the Vaux stria in keratoconus patient. And of course, ocular surface, you have this fluorescein positive corneal ulcer. So slit lamp examination is the basic examination. We should never forget that we start from there. And of course, we can carry on with optical coherence tomography of anterior segment, useful to evaluate, for example, the depth of a corneal scar or the progression of corneal hydrops in keratoconus, as you can see here, or corneal thinning in corneal ectatic disease, or even the corneal demarcation line after cross-linking for keratoconus. And for corneal surgeons, it's also useful for detecting sometimes detachment of the DMEC graft after endothelial keratoplasty. Now, scanning corneal confocal microscopy is also useful for ultrastructure examination of the cornea in vivo. We can actually assess all types of corneal cells, epithelial cells, endothelial cells, keratocytes, and also the corneal nerves. And most important, it has significant clinical relevance in corneal infection. In acanthamoeba keratitis, we can detect the cysts, which could also lie deep in posterior stroma, even predesematic. or the filaments in mycotic keratitis. We can quantify the corneal innervation also in corneal disease such as diabetic corneal neuropathy, where we have decrease of the corneal innervation, or after herpes infection. And of course, measure the endothelial cell density. Now, corneal topography is a gold standard for detection of corneal ectatic disease. Is a major tool for every corneal and refractive surgeon to assess anterior and posterior surface of the cornea, to evaluate corneal curvature, corneal thickness, anterior and posterior corneal elevation. There is a ton of metrics that help us to evaluate posterior and anterior corneal surface, but the big advantage of the Scheimpflug imaging is, of course, the access to the posterior surface of the cornea. As I told you before, it's the major tool for diagnosing ectasia, keratoconus, ectatic disease. And you can see here the displacement of the thinnest point compared to the apex of the cornea, and anterior and posterior back elevation in keratoconus. And of course, wavefront analysis is another tool that every refractive surgeon is using to define the barometric profile of the cornea so that we can make decision on the treatment approach for our patients. You can see here the quality of vision in a patient with root mean square of 0.14, and as the aberrations are increasing, you can see that the quality of vision for the patient is decreasing tremendously. Now, finally, we have the possibility to assess corneal biomechanics in vivo by using two devices at this point nowadays. An older one, the ocular response analyzer, which is a combination of an air puff tonometer together with an infrared camera detecting the inwards and outwards applanation of the cornea after NAIR stimuli has been projected onto the corneal surface. And we have the Corvis, which is has been actually recently introduced in the market with its current software program. It's an air puff tonometer with a Scheimpflug camera. And with the ocular response analyzer, we have metrics such as the corneal resistance factor and the keratoconus probability match. Actually, we have a confidential interval. The machine is telling of 95% for the cornea to be normal, to be suspect for ectatic disease, or to be diagnosed as ectatic cornea. And with Corvis, we have a huge number of data information that we get by the machine, and they all are integrated in a metric, in an index, the Corvis biomechanical index, telling us actually if the cornea is behaving as a normal cornea or as an ectatic cornea. And it's very useful as an adjunct diagnostic tool in cases where we have corneas lying somewhere in a gray zone between normal and ectatic, so before planning any refractive procedure. To sum up, slit lamp microscopy should never be neglected because it's the basis for corneal assessment. Anterior segment OCT is useful preoperatively for planning corneal refractive procedures, but also for post-op assessment and evaluation of our patients. Confocal microscopy has more research implications in the cornea field, but has clinical relevance in assessing corneal infection, particularly acanthamoeba keratitis and mycotic keratitis. Scheimpflug imaging is the basic tool for corneal refractive surgery, and evaluation of the corneal biomechanics by Aura or Corvis is also an emerging technology that could be useful for increasing the safety profile of our patients and providing better results in our refractive procedures. Now, as Secretary of the EVER Cornea section, I would like to invite you all to our EVER Congress, which will be held in beautiful city of Nice in France, middle of October. We have a very strong program with interesting symposia. The Greek presence is also very strong, and I'll be happy to welcome many colleagues from Greece. And I thank you for your attention for my first talk.